Should we start? Or wait a minute.
You're ready.
Well, thank you all for coming to the town hall meeting on COVID-19 vaccine. Today is truly not a vaccine talk, but much more of a variant talk. And then Dr. Lin will talk about the newer guidance about pregnancy and lactation. Dr. Mullane, Dr. Katie Mullane, Kathleen Mullane, who is at the University of Chicago in infectious diseases, will start the conversation today with a talk about all the variants that you're listening to on the news and get into a lot of the nitty-gritty of this so we can explain to our patients and our fellow physicians about what's going on. So Dr. Mullane.
Do I get to control the slides or?
You can say next slide and I'll do that for you.
Okay, next slide. Okay, so this coronavirus is really different from what we have seen in the past. So many of the older coronaviruses were like the common cold, were very stable in their genomes. All the coronaviruses have an error correcting polymerase. So while it's being replicated, a polymerase goes back and fixes errors that occur, but it's not perfect. And so there can be errors that occur that the virus can't live anymore. And there can be errors that make it more infectious. And there can be errors that don't change anything at all. So when we looked at MERS in the past, there were monoclonal antibodies that were made to try to treat that. And it was shown that if there was a single gene therapeutic monoclonal antibody, that resistance to the virus developed quite rapidly. And so I think that portended what we were going to see with the SARS virus. Next slide, please. So with coronaviruses, there's 4 different genera, and the SARS 1 and 2 fall into the beta genera, and in a subgenus called Sarbecovirus. And this subgenus has 4 other coronaviruses with it, and they only infect horseshoe bats. So probably were the thought of this coming from bats and hopefully not from a lab in Wuhan, is from the trees that we see of where this came from. We know that SARS-CoV-2 is not a recombination of any other sarbecoviruses that have been detected to date, and the receptor binding motif on the spike protein is ancestral. It's on all of the viruses and has not acquired any recent recombination to develop it. So when did this divergence from the bat to the human occur? Well, as you'll see on the next slide, there is a period of time between 1948 and 1999 when they go back and look at the genetic analysis to say this is the time that it may have switched over. And so it may have been circulating in bats unnoticed and maybe in a few humans since earlier on in the mid-century. Next slide, please. So this kind of just shows us the coronaviruses, which ones are infecting humans, which ones are infecting bats, which ones have infected the pangolin, and the pangolin is as well eaten in Wuhan as a delicacy. And as you can see on the bottom there, the sarbecoviruses that have switched over, it looks like about 1948 to 1999 that there was a change that came close to the one that we're seeing now in humans as SARS-CoV-2. Next slide, please. So now we have a new headache. We have a lot of variants that are occurring. So RNA viruses mutate, that's what they do. And so when we see an error in the misprinting, as I said before, it can be terminal, meaning the virus dies off. It means no significant change. It could be a change that results in a significant change in the genome that makes it more infectious, and that's our bigger concern. And we know that some of the viruses, RNA viruses, mutate quickly, like influenza, and some slowly, like measles. And then when we first started looking at SARS-CoV-2, we thought it would be about 2 to 6 times slower than what we see with influenza. But I think we're seeing a lot faster, probably because the pool of people in whom it can mutate is so large. And we don't know how fast or significant the mutations are going to be, but we do have some information from the ones that have already shown their faces to us. And so there's hundreds of variants that have been evaluated, and a lab in Israel has shown every single nucleic acid has a mutation that has been found. But not all of them are very concerning. There's several that are called variants of concern, and those are the ones that we'll talk about. And I think it goes towards what's going to happen with the vaccines in the future. Are we going to need one vaccine in our lifetime? Well, obviously, I think we're finding that's not true. Is it going to have to be annually? We don't know. And we'll have to find out as things progress if we can control the epidemic and we don't have so many people being infected and carrying virus and allowing mutations to occur. Next slide. So more circulating virus equals more mutations. So the more viral variants that are circulating, the higher the likelihood that persons can be infected with multiple strains, the higher the likelihood that we can see recombination, and the higher the likelihood that we'll see new viral variants. So as 25% of all infections in the world are in the United States, we are a melting pot for variants to occur. And so it's very concerning. Next slide. So the first variant was actually the first virus that was seen here in the United States. So in Eastern China, this variant B1, which was a single point mutation, occurred. And that one went from China to Europe and then rapidly through the United States and was seen in Seattle and California as our first variant. And this was a mutation in the spike gene. And it really didn't cause any difference as far as infectivity or as far as, more importantly, the vaccine. So we see no change in vaccine efficacy with it, and we see no change in the efficacy of the monoclonal antibodies that have been developed for it. And it makes up, at this point in time, 99% of the infections in the United States. But as there was a nice article in the JAMA today showing that in California, a new strain has come out, and that's probably their widespread one that's causing all the issues there. So of note, the very first virus before this mutation was not very transmissible. And so that may be the reason why in Wuhan and in Beijing, they were able to control the virus much more so than we were when this variant, and Italy was when the variants came across. Next slide, please. So the one that we're hearing most about right now is the UK variant, or B117. This probably occurred in a patient with multiple myeloma who carried the virus for a very long time, at least 110 days before he died. And they followed the swabs on him to look at the genetics and saw changes that occurred. And this carried through the same D614 gene that was preserved from the initial virus that presented itself here, but added a couple more mutations, the H69V70 and the Y44/45, which is a deletion in the genome. And this altered the shape of the spike protein. So the concern is that it may help evade antibodies, but it appears so far that the monoclonal antibodies that we have and the vaccine covers it well. Scary now, the next mutation that we'll talk about, E44, has now become part of the UK variant as well. And so it's concerning that that may be one that will be spreading quickly too. So the 501 deletion is directly within the receptor binding domain, and it allows the SARS-CoV-2 virus to bind tightly or latch on to the ACE2 receptor site better. And it makes, unfortunately, our COVID tests not as accurate. So we may miss a lot of people who are infected with COVID if they have this strain. The P681H mutation is also makes the virus much more infective, and it allows the virus to make new spike proteins much more efficiently, so it can have more receptor sites that the virus can, or more spike protein to allow increased mobility to get to the ACE2 receptors. Next slide, please. So by November, so it showed up in September. By November in England, it was 5 to 10% of cases, and now it's 70% of cases in the UK. We think it arrived in the United States in December, and it's estimated that it's doubling every 10 days. It's been identified in over 70 countries and at least 33 states in the United States, and is projected to become the dominant US strain by March. It's been shown to grow better in cell cultures, to replicate faster in the mouse model, to be more transmissible or easier to spread through mouse model infections. And the death rate may be higher, and that was just recently reported. We thought initially it wasn't, but now it may be because more people are infected, more people end up in the hospital, so the death is higher, but it's also concerning that it may be just virus related and the virus may be more lethal. So antibodies collected from people who've been vaccinated with the current vaccines have been shown that they can neutralize B117. And so we're hoping that if we get people immunized in the United States quickly, we'll be able to control with herd immunity. But as I said, we now know that there's a concern for E484 that is being seen in some of the B117 variants, and we'll talk about that next. So next slide. So the South African variant, or B1353, was first identified in Nelson Mandela Bay in October, and in December it was identified in Zambia, and then we saw all hell break loose in South Africa with increasing hospitalizations and mortality. It's got 8 to 10 mutations in the spike protein. It has that same 614. It has K417N, which again helps the virus bind more tightly to the ACE receptor site. It has the N501Y, again, which helps the virus latch on better, but it also has this E484K, which is an additional mutation on the spike protein. And it significantly alters the shape of the spike protein so that it kind of folds in on itself. And therefore, the antibodies that we have can't bind onto it the way that we saw in the past with our older viruses. So plasma from people who had been infected before did not neutralize this virus. The currently engineered monoclonal antibodies did not have any effect in patients' survival or hospitalizations with this virus. And from neutralization studies that have been done, the current vaccines are less effective, not zero effective, but less effective. So with the Moderna one, it's about 10-fold less effective, but still that makes it about 70%, which is pretty good. It does not contain the deletions that we're seeing in 69 and 70 or the 144, 145 deletions. It's resulted in a second wave, as we talked about, in South Africa. It's also been identified in 11 countries in Europe and Asia, as well as in the United States. And the concerning thing in the US is that the cases that were found in Maryland and South Carolina had no connection whatsoever to anyone from South Africa. So that means it's in the community. Again, we don't have the data that we need to see where the impact is going to be in the US. Next slide, please. So the newest kids on the block are the Brazilian variants. There's 2 of them, P1 and P2. They were discovered in December. The first one was detected in Japan, where in the airports they test everybody. And there were 4 Brazilian travelers that came through, and they saw that the virus that they were carrying, because they sequenced them frequently at the National Institute for Infectious Diseases there, and they saw that this virus was present and that it carried the same mutations essentially that we see from the South African virus, plus a few more. So in Manas, Brazil, 75% of the population had been already infected with the earlier variant of SARS. And in October, there was a huge surge. And when they looked at those people, they had been infected previously, and now they had this new variant. So it was a recurrent infection in that case. So P1's been identified in the United States. P2 is also in the United States. It was first identified in Rio de Janeiro. P1's in Minnesota and Oklahoma. And we believe it's probably spread to most states already. And P1, not only is it in the United States, but it's in Italy, Germany, South Korea, and Japan. So these viruses, once they get going, they really spread quickly. Next slide. And the last one that we'll just quickly talk about is the Danish variant. It's B1426. It was thought that this was responsible for the surge in California, and maybe yes, but probably no, because from the report today, we see that the mutations in the California strain, which is going to be called Cal20C, are totally different from the mutations that we've seen in other strains. So this Danish variant doesn't share any of the mutations either that are on the strains in Brazil, South Africa, and the United Kingdom. We think that its infectivity compares to previous strains, but we really don't know. And we don't know the efficacy of monoclonal antibodies for it. Next slide. So I just wanted to say, how do we test? Are the vaccines effective or not? And what we do is we take cell cultures, we grow virus up in them, we take plasma from people either who've been infected with SARS in the past or from vaccinated people, and we look to see if the virus is able to replicate once that's added. So that's how we know if our vaccines are working with the newer variants or not, and this will be going forward how we'll best guess, because the vaccines that we have now have not been studied on the variants that are coming forward. And so when we look at Moderna and Pfizer, these variants weren't around when those were being studied. When we look at Johnson & Johnson and the ones that are coming after it, they will be effective against the viruses that are present at the time the studies are being done. So our whole thought of having the same protocols for these vaccines, so we could look at them and say, are they equal or not? That's kind of gone out the window because we're not going to be able to have them as comparisons anymore. That's all I have to say.
Thank you, Dr. Mullane. That was truly depressing. Listening to that.
I know it is.
And interestingly, our infectious disease group and have been watching this, and it's become more and more. Take a deep breath every day. You see these variants coming out.
I know.
So Dr. Lynn's going to talk about vaccinating pregnant and lactating women because the WHO has come out with a little bit different a statement. And this is important because we're getting a lot of questions from pregnant and lactating women about whether to get vaccinated. So Dr. Lynn.
Thank you very much, Dr. Chandi. I hope to be a little bit less depressing and a little bit more optimistic. May I have the first slide, please? And to be, just remind the audience, and I'm kind of framing my remarks to those discussions that I want to encourage you to have with your patients. And the first thing I like to stress is the importance of vaccination, and especially realizing that vaccination has not been something that is new in the world of obstetrics. We've been vaccinating patients in anticipation of getting pregnant and during pregnancy. You know, and most commonly would be influenza and Tdap, because it's been shown to be beneficial both to the mothers and to the babies in neonatal life. I want to stress that the current COVID vaccines have not been specifically tested in pregnant women. And this oversight has caused a lot of consternation amongst my colleagues in our organizations, but the reality is the reality. But we certainly have been tracking women who have received the vaccine, and we are also looking at the science behind it. The thing that you have to stress is that the COVID-19 vaccines cannot cause COVID-19 infection. We are not giving an attenuated virus. We're not giving a live virus. We're actually giving a little section of code on RNA, which is converting the muscle cell and the surrounding lymphatics into little protein factories, which will be producing the targeted mixture of spike proteins and causing those cells to now be immunologically a source for antibodies and T cells against these proteins. And for that reason, we feel that these vaccines are safe. And may I have the next slide, please? So here's the recommendations in pregnancy. When I say ACOG recommends, that's also in concert with the Society of Maternal Fetal Medicine. And interestingly, as many of you may know, the World Health Organization had a different view, which has recently changed. And I think it was a great effort on the part of these American organizations to convince the World Health Organization that vaccines should not be withheld from pregnant individuals. I know there was some publicity a week ago about a frontline worker who was, a physician who was pregnant and her employer denied it. And we're urging, as well as the CDC, that this should not be the case. That patients should be offered the vaccine, as part of a counseling. It's really up to the patient, and realizing that they should fall into the same classification groups that the ACIP has developed when their turn is available. And our recommendation, is that they should strongly consider becoming vaccinated. Why? Because the infection is probably much worse and puts the mother at greater risk in reality than any theoretical concerns that we could dream up about these vaccines. May I have the next slide, please? In your discussions with the patient, we like to look at the level of activity of the virus in the community and the potential, and we talked about the potential efficacy of the vaccine, and look at the risk and potential severity of maternal disease, as well as the effects of the disease on the fetus and the newborn. Again, to reiterate, we now know that we have accumulated case series, and it seems to be pretty obvious that the infection can lead to a more severe outcome for women, leading to more intensive care stays, as well as impact on the pregnancy in terms of prematurity. And for this reason, again, we are strongly urging people to consider this. I'd like to, again, point out that these are very safe vaccines. And in terms of the reactions that people are seeing, matter of fact, many of the concerns that we first were seeing, we realized these episodes of anaphylactoid type reactions and others are now, when you look at the total number of people vaccinated, we're seeing that they're even increasingly more rare. May I have the next slide, please? Even less of a concern should be lactation, and both the ACOG and the Society for Maternal Fetal Medicine strongly recommends, again, that these vaccines be offered to lactating women. There's really no biological basis to be concerned. And even though we don't have the clinical trials we would love to have to be able to quote, these statistics, again, the theoretical concerns regarding the safety absolutely do not outweigh the potential benefits of being vaccinated and trying to avoid the infection. The next slide, please. A similar types of counseling will occur with patients who are contemplating pregnancy. And there is no reason and no recommendation to delay pregnancy after completing both doses of the COVID-19. And if an individual becomes pregnant after the first dose, we encourage the second dose to be administered to achieve the type of immunity that we're desiring. Now, you probably are aware that the CDC has a VSafe program that we encourage our patients to download the app and enroll in it through the CDC website, and report back to the CDC, any sorts of issues if they're experiencing. Clinicians should use the VAERS program the CDC has put out. So if you have a concern in a patient, you can register your concern about what you think may be vaccine related. The next slide. Now this is a little bit of the hot off the presses good news from last week. This was published in actually JAMA Pediatrics. It's a relatively small study, but I think it's very interesting, and I agree with the conclusions of the accompanying editorial. In this study, they looked at patients that were infected with the SARS-CoV-2 infection, we call the COVID-19 for convenience. And they found that 72 out of 83 women were seropositive for the infection. And they demonstrated transplacental transfer. So in the cord blood, they were able to isolate the antibodies. So this is something I think that's very important. And even though we don't have the same data for vaccine, we have to assume that since the antibodies are similar, that the same process is ongoing. So in other words, a woman who's vaccinated has a very high probability that there will be transplacental transfer of the antibody, which is hopefully protective to the newborn. And this passive immunity, we see it in other infections and other strategies for vaccinating to specifically achieve that end. And the transfer ratios were associated with the time lapse from the maternal infection and not related to the severity. So the longer the patient has the opportunity to transfer the antibodies, the greater amount was seen. So this is something new, and we're certainly interested in this. I just wanted to share it with you tonight because I think it is a positive message, and it's again, it's not ironclad proof, but I think it should enter in your counseling discussions to explain to the patient that there may be advantages to be able to protect the newborn from the infection. So I thank you, and we will continue with Dr. Chundi.
Thank you, Ed. That was uplifting that the babies are going to be safe, and hopefully the moms will be safe with this. So the current issues with COVID, Dr. Mullane has covered a lot of the variants. So I'm going to skip through some of these slides that I had. Next slide. So this is part of our objective my objective is to understand the epidemiology and the factors associated with the current pandemic. And then the current state of sequencing SARS-CoV-2, because one of the reason why you're seeing all these strains named after places is simply they're doing more sequencing over there for the proportion of cases that they have. Interestingly, the United States has more sequencers than the rest of the world combined. We have more Illumina platforms sitting around in Chicago than some of the countries that are sequencing this, yet we are probably utilizing 10% of our capacity at best. It's very frustrating when you know some of this stuff. The current mutations in circulation and implications of these mutations have been covered, and vaccines and their role in the pandemic we're going to touch on. Next slide. So this is the calm before the storm. So you can see that our cases have fallen significantly. We're, I think, under 100,000 cases now. This is from the New York Times, where I get all my scientific data now because it's faster than the literature. The deaths have fallen significantly. And in fact, if you look at our current pandemic compared to what was going on in July, May, June, and July, we have a lesser proportion of death because I think we've gotten better at managing a lot of the patients that unfortunately are stricken with this. Vaccination rates have increased about 1.3 million doses a day. Today, Joe Biden announced that he bought another 200 million doses of vaccine, which means another 100 million people will have access to vaccine. And the rollout can be best said as rocky if you're being kind to the folks rolling out the vaccine, because it's a complicated process, but it could have been done much better. So viruses change significantly. It's easier to transmit and has some degree of resistance to antibodies and vaccines, as Dr. Mullane has pointed out. Next slide. So why is this a calm before the storm? You're seeing rates falling because most of the strain that's out there was the old 614 strain. And as it's being replaced by the B117 strain, you're going to see another surge unless we change our behavior. And the proofreading sequences we've talked about already, and I would suggest that folks who want to look at this science behind it, look at this article in Science with recurrent deletions in the SARS-CoV-2 spike glycoprotein, which are driving some of this antibody escape. It's actually a well done article. So I would refer to you to that article by Kevin McCarthy. Next slide. So these escape variants are what's driving this. And normally the escape mutations occur in 1 to 2 mutations a month. And a person, the SARS-CoV-2 basically is a fairly stable virus. If you look at somebody with HIV in a single person, they may have 100,000 mutations, different variants in their body. Whereas this virus really peaks within a few days, and then the viremia drops quickly in these RNA respiratory viruses. But a small group of people, a small subset of people are driving the immune pressure. And these are folks who are immunocompromised or getting convalescent antibodies. And in fact, the UK strain really does have like a patient zero, the B117 strain, and we should kind of stay away from talking about South Africa or the UK. We should really kind of try to refer to this as the variants that are out there, because just remember, the Spanish flu did not originate in Spain. It was from Kansas, but we successfully marketed to the Spanish, so it's now known as the Spanish flu. And the reason why the UK and South Africa have notoriety is they are simply sequencing more, just like the Danes are sequencing more than we are. So there are 4 ways that viruses mutate: by immune pressure. So that means replicating in someone with convalescent antibodies. That's what's happening here with the immune pressure. Natural variation, and there's lots of recombination events. That's what happens with influenza. And then there's some cross-species variations. And you saw a bunch of minks get infected here with coronavirus, SARS-CoV-2. And SARS-CoV-2 exists in nature, in basically bats and humans, and then you saw the poor pangolins, which I guess are made. They use the scales of this pangolin for a remedy. So the pangolin seems to be the intermediate host. In SARS-CoV-1, they had that poor creature that I forgot the name of it. Katie, do you remember that the Chinese wiped out, thinking it was the intermediate host, but it wasn't. It was simply eating the fruit from the bats that were being dropped down in SARS-CoV-1. It looks like a raccoon. I forgot the name of the thing. Next slide. So this immune pressure, we noticed this in our own group when we published this in a transplant journal that looked at transplant patients, and we found a couple of patients that kept turning positive. The civet cats, thank you. So it kept turning positive, and we cultured the virus, and it was going on for more than 50 days in about 4 of our patients. And this is the type of patient that gets escape mutations, because they are constantly replicating virus as their immune system is ineffectively clearing virus, and they don't mount a good neutralizing antibody. And this has now been, and it was published in the New England Journal with their own series, and now they're looking at solid organ transplant with immune pressure. Next slide. I wanted to give a shout out to Dr. Hahn, who put that together in our group. So genomic sequencing is how you figure out where these variants are. There are about 30 base pairs in the SARS-CoV-2. The US ranks is the world's superpower in genomic sequencing, but we're 36th in SARS-CoV-2 sequencing. And we have more sequencers than anywhere else. And it has to do a lot with putting the dots together. There's a shortage of pipettes right now, believe it or not, to get the sequencers online. There's a shortage of funding to do this. There's also a difficulty with getting the labs, the specimens, and the CDC is working hard right now to try to get at least about 5% of the samples sequenced. That would be 36,000 samples a week to get a good idea of what's happening in this country, so we can actually deal with the pandemic with some science. So Dr. Mullane pointed out that the B117 variant is doubling every 10 days. It's about 35 to 46% more transmissible, and it will become the dominant strain in this country. And as you can see, like in Chicago, we opened up the restaurants, we've opened up society at a time that this variant is increasing. And it may be not the smartest thing to do, as now the virus has changed significantly. It accounts for about 4.5% of new cases in Florida by late January. So this is a huge problem, because the variant is going to overtake the current, the B117 variant is going to overtake the current virus that we have, and it's going to cause another surge. A lot of the mathematical modeling shows March, April. And we're hoping that the weather clears up, it doesn't get as cold, people are able to be outside, and that may help quite a bit. Next slide. So why is this viral sequencing important? You can figure out by viral sequencing emergence of new viruses. You can figure out the phylogeography, where this virus has gone and how it's spread. You can figure out population dynamics of the number of people infected and how the virus is spreading amongst that population. And then you can figure out the adaptation of the virus based on the sequencing. That's why it's really important to get good sequencing data, so we as a group of scientists can actually have an idea of what to do. Next slide. So this is fairly hot off the presses as of February 7th of sequencing, and this is all publicly available data with GISAID, and you can go to their website. It's a fabulous website to figure out all of the various sequencing and where everything is spreading. And you can see Illinois can't be number one, so we're going to be somewhere between 0.5 and 1% of sequencers. Washington, Wyoming, and Maine have done quite well with sequencing, but it's still below the threshold of 5% that the CDC is shooting for. So we have a long way to go to sequence to actually know what the virus is doing and where the virus is. Next slide. So what are the drivers of this pandemic? And this is something that we've learned. So there are some things we've learned in this pandemic. And the driver, this is a nice article published in Science, that's age groups that sustain resurgent COVID-19 epidemics. And I can thankfully say I am not part of that age group anymore. So individuals aged between 20 and 49 are the only group that are sustaining the resurgent SARS-CoV-2 transmission with reproductive numbers well above 1. And at least 65 out of 100 of the COVID-19 infections originate from this age group. Next slide. So this is based on over 150 million cell phone data, which they were able to then run Bayesian models. And basically what they found was this group of individuals between 20 and 49 are disproportionately spreading the virus all over the country. And interestingly, when the schools were open at that time, children did not account for spread of the virus. And it's pretty compelling data that shows that the age group that's really spreading it is that specific group. And I would suggest that, if you have a little time on your hands, this is actually a very good read, that the schools are not the source of the outbreak, and the children do not account for, there's not zero transmission, but they account for just a minority of the transmission. Next slide. So these are the variants we talked about, and that Dr. Mullane pointed out to. Originally it was a G614 strain, now the B117 strain with the 501YV1, and then you have the what's called the South African strain, the B1351-501YV2, and then you've got the P strains coming out, and then they have key drivers to resistance seems to be this E484K mutation, which is very scary. Next slide. So this is from GitHub. It's actually a nice site if you want to go see how the virus is being spread and how they're sequencing. Now, you have to remember, the countries that look the worst are the ones that are doing most of the sequencing, because it's a bias of who's looking the hardest. So this has to do with the B117 strain, and then most of the sequences were done in England. That's why England is very dark, and you can see that, you know, if you're Russian, you're real happy. If you're in Africa, you're real happy based on this, but that's really not true. It's because the sequencing data are not available out there. And interestingly, India has also started sequencing quite a bit, and they're getting better data out there. Next slide. And so colors indicate the imported cases and where and how it's being imported. And you can see that local transmission is taking place in the United States, in South America, Africa, and as well as Europe. And next slide. And you can see the dates of sequencing here. The darker the dates, the earlier it was detected. So the darkest are, of course, in England, Australia, and then the United States, and then you can see it also spread from India. And it's really colonial. If you think about it, it's where the old colonial British were. Next slide. And this is very interesting. There's really good data about where the flights originate from, and you can actually match where the virus spread to. And you can see Spain and Italy, Greece, Poland, Germany, Portugal, Turkey, and you can see that the countries where most of the people traveled from Britain were where the virus then spread to. And so the data are pretty good about how this is being spread. Next slide. So this is the B1351 strain that we're very concerned about, from that was first sequenced in South Africa. And again, you can see the darker color is where the sequencing occurred in October. You can see in South Africa, and then in Australia. You can see in Britain where the sequencing took place, and then the sequencing with the lighter green is closer to today, of where the what's called the South African strain, but really the B1351 strain was detected, date of earliest detection. Next slide. And then you can see the logged sequences of variations in each country. Countries with more sequences are shown in darker color. So this is where really the sequencing is occurring more and more often. Next slide. And then local transmission. And this is why the ID world is very upset. And you can see that local transmission is taking place in the United States, and it's probably taking place in a significant level. There was a chat about the Illinois finding a case. Well, it's not at all inconceivable that it's in Illinois. It's probably everywhere. We're just not looking for it hard enough, and we will find it when we look for it. It's just a matter of, and I don't find anybody that's disagreeing with me in the infectious disease world, epidemiology world, saying, you know, what you're saying is not true. It's just we're going to look for it and we're going to find this. So this is a very big problem for all of us, because it's going to basically take away some of our monoclonals. It's going to make our vaccines a little less effective, and then we're going to have to re-engineer the vaccines for this. Next slide. And again, this is air travel data from the same GitHub. I would suggest, if you really are interested in this, to go to that site, because you can look up all sorts of interesting data, and you can look at countries, and you can look at different variations. So you can see where it's spread in South Africa and what countries people travel from South Africa, and the air travel, and basically it matches to where you're going to find the virus. Next slide. So where is this all going? So hopes of control and eradication are effectively fading because of the amount of cases. Basically, the viremia, the viral load of this country is so high, and the immune pressure is high enough that we have significant amount of viral escape and viral and variants out there. And so what we're going to have is you're going to have a pandemic which becomes endemic throughout this country. So vaccination is difficult. And there are many factors, including the fragmentation of care, the logistics, the hesitancy, the inequalities, and now escape mutations that are driving. We can sit here till midnight talking about this. And what we do know is asymptomatic transmission in younger age groups is a major driver of this pandemic. And eradication will require sterilizing immunity. And it's not been demonstrated that you really get sterilizing immunity with this vaccine like you do for smallpox vaccine. And there's no evidence that it prevents carriage, and then there's no global coordination. It's not good enough, as the travel slides have shown there, that you eradicate in one small country unless you're going to close off the country forever. So if you're sitting in the Mauritius, you may be okay, but this is not the Mauritius here. This is the United States of America, as they say. And a lot of people come in and out, and so we're not going to be able to eradicate this unless the whole world gets on the same page and we all vaccinate together and we decrease the amount of global viral load. I guess you can call it a global, is that inappropriate? I guess global viral load to decrease escape mutations. So what we do know about this virus, and it has a lot to do with infection control. We're going back to infection control. And that slide that showed that schools are not a major source of transmission is because schools have 6-foot distancing rule. The kids are wearing masks. We thought kids could not wear masks, but kids do wear masks very well when appropriately instructed. Hand hygiene is important. And if you wear a mask and you socially distance and you wash your hands, those are really effective measures of decreasing the community viral load. And I think that message comes through clear. The more complicated things of air exchanges and engineering buildings, those are things that have not been studied in a nice scientific way, but these 3 things we do know work. Immunization does work when you have effective vaccine. Now, the good thing is these vaccines are still effective enough, with whether it's the Pfizer, the Moderna, and I think I can say the J&J vaccine is still well over 50% effective, even for the South African strain, that you should be able to get a decent amount of herd immunity to decrease the amount of viral load in the United States to hopefully make this just an endemic virus. Next slide. So what will probably happen is the coronaviruses are childhood illnesses which have been there for a long time. And this will probably cause a mild illness in infants, which were much more deadly before they were adapted. So these are not new viruses. These are viruses that have been around for a while. Recent publications have shown eventual death rates to be the same as the common cold. This was published in a mathematical model in, I think it's Science, that looked at what's going to happen based on various scenarios. And if you vaccinate all who are susceptible to die or be hospitalized, which is over 65 people with comorbidities, what you will have is the age group that was spreading most of the virus, which doesn't get that sick. You see all these folks all over TV going, why should I care? I'm not the one that's going to get sick, So if you vaccinate people over 65 and you vaccinate the folks that are much more likely to die or be hospitalized, then what you will have is much like influenza. You'll have a group of folks that do have influenza and spread, but will lead to much fewer deaths, and you'll have a functional society. Dr. Townhall wrote a commentary about a pan-coronavirus. Now, this is a virus that you potentially can make a pan-coronavirus because you've got a nice juicy spike protein presenting itself to the immune system. And it's just a matter of figuring out which part of the virus that will do this. It will just require a global effort and a lot more money being put into this. Next slide. So we have had a lot of interest from various community groups for lectures. And so we need to match up folks that can speak Spanish. They need folks that can speak Mandarin because a lot of the ethnic communities do want people from the medical society and physicians to help out. So please sign up. We will have now a group of organizations. We reached out to the city of Chicago. We reached out to Cook County, and they're matching up the trusted messenger with groups that require vaccine lectures. The other part of this whole puzzle is going to be vaccination sites. We are going to have a lot more vaccine available, And if we can volunteer to assist in these vaccination sites, it would be great. We have a website, vaccinatedchicago.org. It's not just for Chicago, but all the collar counties. And I think if we as physicians who really want to get out of this mess as soon as possible, do as much as possible, we'll be able to help at least get enough herd immunity where we won't have so many of our colleagues and friends falling ill and dying. So we're a little early, but I think we can stop there and then answer some of these chats. Dr. Lin? Or Dr.
Yes, thank you very much, Dr. Chundy. I think a lot of the questions in the chat we made an attempt to try to answer them. I think that maybe it's worthwhile just reviewing some of the things. The issue of Guillain-Barré it was raised about a patient that had it 40 years ago. And I think that Dr. Mullane felt that there's no reason not to offer vaccine to these people. Dr. Chundy, do you agree?
I think I have not heard that Guillain-Barré is associated with this virus. So I think it's perfectly safe to give it to people who had Guillain-Barré.
And we've already talked about the pan-corona. There were some questions about maternal fetal transmission of the infection. It's not been documented to my knowledge, but we do know there's maternal fetal transmission of the antibodies. And there is no reason to delay vaccination to the second or third trimester. All you're doing is increasing the woman's exposure to becoming infected. Again, biologically, this virus is not a virus. This is a mRNA segment which has been created, and all you're doing is eliciting an immune response for the protein, so it should not be teratogenic. The issue of ITP cases, I know it's getting a lot of publicity, and I know that some experts have come out recently and say that it is highly likely that it is related to stimulation of the immune response, but that it also could be individuals that are predisposed to it because of prior history. The truth is these are being looked at, and the CDC says they're investigating this. Now, do you have any further thoughts about this, Vishnu?
We've actually seen natural infection also cause a severe ITP. Like we've had someone come in with like a platelet count of like 0 after natural infection. It doesn't seem to be, it doesn't seem to be out of proportion to what you would expect from other. And measles also, MMR also causes an ITP-like syndrome. But compared to the amount of mortality and morbidity associated with natural infection, I think the vaccinations are still considered safe and should not be withheld. Do you have any other, Dr. Mullane?
No, I totally agree with that.
It's scary, but you know, the vaccination itself is unbelievably safe compared to our prior vaccinations, with whether it's a smallpox vaccine or other vaccines. Like it's an unbelievably safe vaccine. That's a good thing. The other thing is the platform, the mRNA platform, lends itself to be quickly adapted to these variants. That's why the sequencing is so important. So you know what you're dealing with, and you can make a vaccine that's a little bit ahead of the game, so you can actually decrease the amount of pressure, so you don't get these escape mutations as often. And I think that's the hope for this. We do have a platform that's malleable, that you can do quickly. The downside is it's not so easy to give. So.
Some questions have come up a little bit about the volunteering and about the Trusted Messenger program that I'd like to cover. The issue of volunteering, as Dr. Shistari commented, and to everybody, and she is a member of the Chicago Medical Society that is working on this program. The role of physician could be as an observer, a vaccinator, some places as a lead MD. Depending how the vaccine is distributed, I can tell you in a site where I volunteer, a physician or pharmacist is drawing the vaccine into the syringe in the proper amount and handling that. It depends on the availability of what personnel is there. In terms of the Trusted Messenger, there was a question about whether we're going to provide them with any educational tools, and I'm grouping the comment together? And the answer is yes. We hope to have a slide set available, which would not be this level of technicality that we went over tonight, but rather more geared towards talking points and potential questions that you could use to present to groups of the lay public, and not necessarily talking to medical people. And that should be forthcoming. And there's also right now availability of material on our website. If you look at the Chicago Medical Society website.
There's a question, Ed, about quarantining after vaccination. The CDC came out with recommendations, and I think the infectious disease world has been fairly liberal about stopping quarantining if you've been vaccinated and you're asymptomatic. And the duration is now 3 months because they're still seeing how long your neutralizing antibodies will last. So you don't need to be quarantined provided you're asymptomatic and you've had both doses of vaccine. And so you still need to wear masks. You can't say, hey, I know there were several of my colleagues who had like vaccine parties because they're all vaccinated, and that is not kosher. So there's a couple of questions about nasal vaccine. I don't think there are data to actually comment in a meaningful way about the nasal vaccines.
Yeah, I don't have any comment on that.
There's a question about what are the efforts to address vaccine reluctance in long-term care workers. That's a great question, because we have seen personally, when you talk to long-term care workers, there's a significant reluctance to get vaccinated because there are many reasons. And I think this is the one place where the trusted messenger has to go and reach out to nursing homes and these long-term care facilities. The people that are most at risk are worried about getting vaccinated. And I think we have, unfortunately, when you talk to the elected officials, they say, oh, we've done all that. We've had our weekly Zoom meetings or whatever, but the people that are coming to those Zoom meetings are not the folks that are so hesitant. I think we have to actually reach out to these nursing homes and other places and go out and do this. Otherwise, it won't happen. The second issue with vaccine hesitancy has been in ethnic groups that Latinx, as well as other ethnic groups that need folks that speak the language and know that area. I mean, you have to look, it helps to come from that community. And so that's why we're reaching out to folks who can speak Mandarin or speak, whether it's Romanian, Polish, Lithuanian, and we can certainly match up folks and reach out to those communities. And anything else? Because I think we're done in time. So
I think we're done.
Yes. So thank you very much for attending, and thank you, Dr. Mullane and Dr. Lin, for participating. I think hopefully take a deep breath and we'll be able to get over this variant stuff. Thank you.
I have to stop having dreams about variants since the last time we discussed it.
Thank you.
Take care, everybody.
Have a good night.